Let me start. Um, Subject matter is really retooling dental health for the Holocaust survivor. So, some of the objects here, we want to engage everyone in the room. That would be physicians, dentists, nurse practitioners, physician assistants, medical students, dental students, nurses, and other healthcare professionals uh, to enhance the value, quality, and affordability objectives for the geriatric healthcare of the Holocaust survivor, to reduce the morbidity, mortality of the geriatric population by creating a paradigm shift. And that is based on something that we're looking in the insurance industry is reimbursing more for value than for volume. And that's the major shift. The Medicaid program in New York State has now shifted its emphasis to the insurers, the managed care organization, based on their outcomes, so that you will no longer be directed at a fee schedule procedure reimbursement. And this is where the creativity is going to take effect. We want to create a geriatric health home for the survivors by advancing a more integrated, holistic approach to geriatric health care. So basically what we're looking at is a two-dimensional overlay to create a dental home. This is so kind of sexy, dental home, medical home. But it should be a patient-centered geriatric health home, a health home, not a dental home, not a medical home, not siloed. And above all, the way we're going to drive that is one way. We're going to drive it through behavioral management to change the way we as practitioners practice dentistry today. And then we'll have a true healthcare professional. That healthcare professional will be reimbursed for early detection, not for just disease treatment and restoration. For care prevention, that's the key to it, evaluation and proper referral. Whole different way of reimbursing. So the challenges we face with the elderly population, physical disabilities, decreased sensory function, emotional disability, lack of means of transportation to get to the dentist, lack of truly trained professionals. So some of the coordinated efforts we have to address oral health needs, and a lack of a cost-effective delivery system. So I had to start paying for early detection, early treatment, even in the elderly. So basically we're stealing a CAMBRA model, Caries by Risk Assessment model, resurfacing it in the elderly. And we're going to manage the patient on outcomes. Maybe it's time to think that we reimburse for non-surgical dentistry, non-invasive dentistry, palliative dentistry, see how the patient turns around their behavioral management, and then start with restorations. So the decay formation, minimal invasive treatment, there are ways to get into that so perfect for our Holocaust and all elderly patients. Okay? So geriatric care management should be a minimal invasive dentistry procedure for the Holocaust survivor, an evidence-based approach whereby the disease is controlled by the dentist and the oral health team. We have to see more preventive dental assistants working in the offices. It was very popular in the 60s, the time of the Vietnam War, and now it's time to bring back that person into your office. But the only way that's going to be viable is we in insurance start reimbursing for the wellness of that patient instead of the disease of the patient. Components of the approach are to conduct oral risk assessment, focus on early detection, prevention, monitoring, with surgical intervention utilized only as an end-state treatment. And then in order for this to work, I have to build a financial model to support that simple concept. And now we want to go to the precise linkage of systemic diseases. We hear so much about it. Is there a one-to-one ratio? It's something we have to take into consideration. If we have inflammation in the gums, in the gingiva, that's not a good thing. So let's look at some specific diseases. In diabetes, of all the results, and there's some wonderful research, and I hate to call it research, but studies of paid claims, that when patients have dental intervention The cost of care in certain oral systemic diseases goes down. Diabetes is probably the best of all, because we're going to go on and show you this, that the precise linkages of diseases is still unknown. There's a synergistic effect. When oral infections arise and go untreated, seniors face heightened risk factors for diabetes, cardiovascular disease, and above all, respiratory. Okay, so in diabetes, periodontal disease, back and forth, periodontal treatment is needed. And when we do periodontal treatment, we have an improved glycemic control. And how do we know that? Just measure the hemoglobin A1C. And we can come back with better by just that intervention. The cost of care goes down astronomically. So something I wrote with a friend of mine, Bert Edelstein, that was published in the New Republic. And basic dental care is not particularly costly. Unfortunately, it is generally restricted to its own silo, separate from the rest of the American medical care. Sun Dental, blah, blah, have argued for a stronger focus on prevention and a greater integration of medical and dental concerns. So, Eleanor Roosevelt, the future belongs to those who dream. We're going to dream that we get a system that everyone can have good health care based on solid business economics and reimbursing for the proper outcomes instead of just billing for the sake of increased revenue. And that's about it. Thank you.
Thank you, Dr. Finkelstein. Now, I am pleased to introduce Dr. Cohen Brown to discuss the importance of oral cancer screenings.
Thank you. So what we're going to do is to go through some of the current trends in epidemiology and the diagnosis of oral cancers. So I am officially the director of RADA's Oral Cancer and Smoking Cessation Program. I'm also a full professor at New York City College of Technology. As I said before, I am an oral and maxillofacial pathologist. So this is one of our basically our advertisements. This is the calendar event for April, May, and June. This was from 2012. We have been meeting annually to do these free oral cancer screenings all over the tri-state area. Probably I've been involved in it since about 2005. They have been written up in Russian newspapers as well, and we are very actively reaching out to the community, to the Russian-speaking community, as well as to anybody who is interested. These are not only for Russian-speaking patients. This is for anybody who is interested. Okay, so let's just talk about some basic oral cancer statistics. There are 30,000 new cases of oral cancer in the United States annually. This has not changed. Of the oral cancer, squamous cell carcinoma is the most common type of oral cancer. We can see melanoma intraorally. We can see perioral lesions. We can see salivary gland pathology as well. We can certainly see things like melanoma in the perioral skin. One thing that is really interesting is that the 5-year survival rate has remained at 50% for the last 50 years. Think about that. Our 5-year survival rate is awful. And part of the reason that it is so bad is that, well, there's two reasons. One is that for those people who are not going to dentists, for people who are going to physicians, and for the physicians in the audience, I apologize, but how many of you have gone to a physician where they've gone basically from the lips to the pharynx and they haven't looked at anything in between and they're just basically going right back and they're not really doing a thorough oral exam? The other issue is that the intraoral carcinomas that we're seeing, especially the later stage ones, are really going to be seen at the base of the tongue, floor of the mouth, right where the two meet. So how many people, when they're doing their oral exam, intraoral exams, are really wrapping the tongue up in gauze, taking the tongue and literally trying to remove it from the person's mouth in a very kind and gentle way, but you really have to do it. The other issues are things like field cancerization. So when I'm teaching oral cancer, one of the things I'm talking about with my students is like when you're drinking alcohol, it doesn't just affect one part of your mouth. If you're smoking cigarettes, it's going to go both into the upper GI as well as the lower GI as well as go into the oral cavity. So you're going to be having the same potential pre-malignant effects that are going to be a attacking multiple areas, and that concept is called field cancerization. And that's going to result in not just one but multiple primary tumors, so that if you have a patient who has a primary oral carcinoma, if they do not stop drinking and smoking, 31% of them will then, within the next 5 years, will develop a second primary tumor. 17% of them will develop a second primary tumor even if they do stop drinking and smoking. So having a conversation about both alcohol as well as smoking is really important. The advanced stage of the disease at the time of the diagnosis. So when you think of lip lesions, they're really easy to find. If you're looking at base of tongue lesions and floor of mouth lesions, they're not so easy to find. So if you're not really looking and you're not really getting in there, the way that we're diagnosing them, they're being diagnosed at a later stage as opposed to like an early stage. Frequently, early lesions are either ignored or not adequately identified by clinicians, and therefore you're getting delayed treatment. By far, tobacco is the most likely etiology of most oral cancers in the United States. I'm going to go with cigarettes first, then pipe and tobacco. Marijuana, that's getting up there, okay? We're seeing an increase in amount of marijuana use. And when you're talking about older patients who are going for alternative pain methodology, even though it is not officially legal in this state, we still have medical marijuana that is creeping in around us, and these people are smoking. So it is something you want to talk about with your patients. In terms of etiology, alcohol is not really a pure etiologic factor. It is a potentiator. It's going to take something and make it worse, so that if you look at alcohol sitting on top of tissue, it's going to cause a dryness or a dehiscence of the tissue. It's going to break apart the intercellular bonds, which is going to allow for better penetration of the intercellular carcinogens. A prior history of having oral cancer is actually a huge etiology. So if you've already had cancer once, the likelihood is you're going to have it again. It's something to consider. And human papillomavirus, wow, we are seeing a major increase in that, okay? The American Dental Association and the Oral Cancer Foundation recommend that an oral cancer screening be done on every new and recall, or they might be calling them recare patients now, okay? The goal of Healthy People 2000, 2010, and 2020 were, at minimum, to get 20% of the patients in this country to have oral cancer screenings annually. This has not been met. Do you want to know how pathetic that is? In the Healthy People 2020, which is what we're going for right now, do you know what they're looking for to have as their ultimate high-end goal? 20% of the patient population, which means that 80% of people in this country are not having oral cancer screening annually. Okay, and only between 14 and 18% of those of dentists are doing screenings on each patient. And what I would like to say is, to do a good oral cancer screening, to do a head and neck exam, it really only takes about 2 minutes. You can talk to the patients, you can tell them you're giving a massage, you can just tell them you're looking whatever you want to be looking for. There's a lot of ways of doing this, and there's a lot of ways of making the patient feel non-invasive, not uncomfortable as well. Oral cancer screening or detection involves both checking for disease in a patient who is currently symptom-free. Case finding is actually the term used for application of a diagnostic test or procedure to a patient with an identifiable lesion, or to establish a diagnosis and to bring the patient to treatment. Early detection of oral cancer actually is rather important. It reduces patients' morbidity and mortality. It decreases the likelihood of advanced or invasive tumors, so that if you can catch a tumor that's a stage 1 tumor, the 5-year prognosis is probably about an 80 or 90%. If you catch a tumor at a stage 4 diagnosis, you're talking about a 20 to 30% 5-year prognosis. So the earlier you see them, the earlier you find them, the better off the patients are going to be. So it's going to improve both short-term and long-term prognosis. And the earlier that you find these lesions, it's going to require much less aggressive treatment with fewer complications or potential complications. Okay, other benefits of early diagnosis of oral cancer is basically you've got less invasive treatment, better treatment outcomes, and higher survival rate overall. Your barriers to early detection. So this is some of the things you want to think about. Well, why aren't people getting early detection? Well, it's asymptomatic. You know how they always call cancer the silent killer? It's called the silent killer because it doesn't hurt. It doesn't hurt until it's gotten involved into the lymph nodes. Once the lymph nodes have gotten involved, or you start seeing an inflammatory response, then you're going to start getting pain, but it's not going to be pain from the tumor. The reason the tumors do not cause pain is that they infiltrate the peripheral neural setting, so that you're actually killing the peripheral nerves. Therefore, they're not transmitting pain. Okay, so the way you start getting pain is once you start getting an infection or the tumor gets quite big. Barriers to early detection, malpractice. People are not doing this regularly. And by the way, you are responsible. You are responsible for doing an oral cancer screening. I would personally, on a personal level, I would recommend just including that as a note. When you are writing your progress notes or whatever it is that you performed an oral cancer screening, just write OCS so everybody knows what it means. Or actually, everybody doesn't know what it means. So if you do use letters in place of words, someplace in your office you have to have that sort of listed and printed, and so that everybody knows that if you come into your office that OCS means oral cancer screening. Just make yourself safe. Economics, people are not coming in because they don't have dental insurance, and there's a public unawareness of oral cancer. Basically, what I would like to say about oral cancer screenings is that a head, neck, intraoral, extraoral exam is still the standard of care. It is what the American Cancer Foundation is saying. It is what the Oral Cancer Foundation is saying. It is what the American Dental Association is saying. Use your hands. Use your fingers. Look and see what you can find. I mean, honestly, I can't tell you how many patients we find things. And as my dad, and I will just say this for my dad, for the last 30 years of his life was receiving holiday cards every year from patients whose lives he saved. And that's because he looked, okay? I mean, it wasn't that I can't tell you, if people are coming over to me and say, well, I've never seen anything. I was like, well, look, you gotta look. I mean, you really have to look. And you can do this very effectively in a small amount of time. The emerging technologies right now are complementary and are not meant to replace a thorough visual and physical oral cancer exam. That's it. Okay, thank you.
Thank you very much. Our final presentation is Dr. Morris Sassone to talk about his personal experiences in working with Holocaust survivors.